Good afternoon, everyone, and welcome to this grand round. So in the next 45 minutes, maybe, we'll try discussing a new, I won't say new, but maybe it's new to us in ophthalmology, new modality of treating basal cell carcinoma of the periocular region. Now, before I go through the slides, it's very important for us to mention here at this setting that the surgical treatment or the surgical excision is still the gold standard treatment for such disease. Yes, promising results are there, but we need longer follow-ups and we need further studies with larger groups and larger number of patients. So for junior residents or for junior ophthalmologists in practice, I would like again to mention, as I will mention in the middle of my presentation and by the conclusion of our presentation, that surgical management is still the gold standard treatment for patients with basal cell carcinoma. Now, as you all know, basal cell carcinoma is a malignant neoplasm derived from the non-keratinizing cells that originate from the basal layer of the epidermis. It's very, very common. It is the most common cancer or neoplasm in humans, by all means. It has been estimated that 2.8 million new cases of basal cell carcinoma get diagnosed each year only in the United States. And over 700,000 new cases annually every year in Europe. So it is very common. It has been estimated as well that 1 in 5 Americans will develop skin cancer at some point of their age or their life. Over those, 95% are non-melanoma skin cancers, which basal cell carcinoma represents the vast majority. Moreover, 40 to 50% of patients with primary basal cell carcinoma will develop at least a second basal cell carcinoma lesion within the next 5 years of being diagnosed with the first one. So we need to put all those informations in mind. Sun exposure is the most common and the most important risk factor for developing basal cell carcinoma. It's a disease of elderly, as we all know, but it has been linked to certain genetic syndromes, such as Gorlin-Gold syndrome, which is basal cell nevus syndrome, or xeroderma pigmentosa, which may predispose children or young adults to skin cancers, most commonly basal cell carcinoma. The pathogenesis of basal cell carcinoma involves the exposure of skin to ultraviolet light B between the spectrum of 290 to 320 nanomillimeter that induces mutations in tumor suppressor genes. Then the patients are more risk to develop skin cancers. Now, in general, basal cell carcinoma are indolent tumors. However, when they are located in the itch zone, which I will explain later, they have higher risk for recurrence. And they usually invade locally, which may result in damage of structures, in vital structures damage. Although most basal cell carcinoma are indolent and slow growing, they may manifest aggressively and may cause perineural invasion, like the squamous cell carcinoma, and very rare with metastasis. As ophthalmologists, one of the manifestations or signs that we need to look at is the brow ptosis, in which usually there is a perineural invasion of the temporal branch of the facial nerve, or paresthesia, which indicates the involvement of the trigeminal nerve. Yes, the incidence of metastasis of basal cell carcinoma is very rare. It's less than 0.5%. But of those 0.5%, 80% have primary basal cell carcinoma in the head and neck region. So this table summarizes some of the risk factors that we mentioned already. The most important one is the exposure to ultraviolet light, especially in childhood and adolescent, in which the tumor suppressor gene gets affected, but tumors usually appear later in life. The Northern European ethnic origin is a very is a very high risk. Beside the light fair skin color, the tendency to burn rather to tan, and the use of tanning beds as well. Proximity to the equator is an important risk factor. Other risk factors include exposure to radiation, immunosuppression, especially in organ transplant patients, HIV positivity, and genetic syndromes like xeroderma pigmentosa or Gordon-Gold syndrome. This is a clinical variance of basal cell carcinoma, which may come with various forms. So the most common one is the nodular basal cell carcinoma, which is the most common and most benign, fortunately. It could be a pigmented lesion as this one. This is another pigmented basal cell carcinoma, which is a large one. And this is the typical rodent ulcer, the ulcerative type, which you can see that it eroded already the area of the nose, the ala of the nose. This is the mustache of the patient. This is a benign form of the disease, which is called a superficial basal cell carcinoma, and it doesn't look like a carcinoma, but on biopsy, yes, it is basal cell. And this is a recurrent disease after excision, so this disease may come at very different clinical variants. Now, this is the H zone. H means high risk, so it was given the H letter because it is considered a high risk area. It's called the mask area. It includes, this is very important to us as ophthalmologists because we are at the danger area. Eyelids, eyebrows, and periorbital area, nose, lips, chin, mandible, preauricular and postauricular, and temple. So this is the H zone, which indicates a high risk of recurrence and an aggressive disease. This is zone M, which means moderate risk. The cheek and the forehead is considered zone M, and zone L is the extremities and the trunk. It was given the L letter because it's low risk of recurrence and aggressiveness. So according to the National Comprehensive Cancer Network, these are the low risk criteria, and this is the high risk criteria. If you noticed, even if you have a more than 6 millimeter lesion at the H zone, this is considered a high risk. On the other hand, you need like 10 millimeter, over a 10 millimeter, or 20 millimeter in the M zone or the L zone. So back to the H zone, we are at the high risk area. Other risk factors include poorly differentiated or poorly defined, recurrent, and as well as perineural invasion. Of course, radiation exposure and immunosuppression are other risk factors as mentioned before. Now, for the second time, I repeat that surgical excision of basal cell carcinoma is still considered the gold standard treatment. The gold standard treatment of basal cell is Mohs, microsurgical, micrographic surgery, which is unfortunately is a few people around the world they have this privilege, I would say, because it's another 2 years of fellowship of doing Mohs, micrographic surgery. Electrodesiccation and curettage is another form of treatment. Cryosurgery was used, radiation, photodynamic therapy, and 5-FU, 5-fluorouracil, and which I will spend the next couple of minutes to talk about is the imiquimod medication. Now, imiquimod is a potent immune response modifier. It works through activating toll-like receptor 7, TLR7, which then secretes cytokines like interferon alpha, interleukin 6, and tumor necrosis factor as well, and it induces apoptosis. So it works through immunomodulation. There is a good evidence that when using a imiquimod cream on the skin, it activates as well the Langerhans cells, and then it activates the adaptive immune system. Other cells that other immune cells gets activated also by imiquimod, including natural killer cells and macrophages, as well as B lymphocytes. Imiquimod has been used successfully and in a wide variety of dermatological conditions such as genital warts, actinic keratosis, squamous cell carcinoma in situ, squamous cell carcinoma itself, and molluscum contagiosum. It has been reported to have a very good clinical effect in management of both superficial and nodular basal cell carcinoma, but not the advanced or the aggressive or the morphiform or the sclerosing form of basal cell carcinoma till now. In a recent study, they compared 202 patients receiving PDT and 198 patients with imiquimod. The imiquimod group showed a superiority in the resolution of basal cell carcinomas, but those patients were having lesions at the trunk or the large or the extremities, and those tumors were large. What about the eye? A group from Spain studied 15 patients and published their article in 2010. So they recruited 15 patients with clinical and histopathological diagnosis of nodular basal cell carcinoma. They treated those patients for 6 weeks, for 5 days per week, so once per day, 5 times per week. Those patients were not primary. So 3 patients had persistence of the cancer or the lesions after PDT, and 1 patient had failed cryotherapy. So you can say that 4 out of the 15 were aggressive disease. Besides, 4 of the 15 had other pathologies, which was considered to be an absolute or relative contraindication for surgery. One patient, for example, had a severe aortic valve stenosis. Another one had a relative refused surgery because he had inoculated eye and he had only 1 eye and he refused to get operated in that eye. Another patient was immunosuppressed because of radiation, and the last one had a very bad cardiomyopathy with atrial fibrillation on antiplatelets. Now here, let me stop here and then say that I believe in the future this is a good alternative treatment in patients in which surgical treatment or surgical management is contraindicated, or in case of patient's refusal for surgery. Then the next step is we look for alternatives. Now all 15 tumors showed clinical and pathological remission at 3 months after treatment, after completing the treatment with imiquimod, and the resolution continued till 24 to 28 months, which was the end of their follow-up. Regarding the tolerability of the medication, it's a potent medication. So 7, which means 50% of the patients had a bad experience with the medication, most commonly representing a local side effect, which we will discuss later on. This is the details of the patients. You can see that all patients had no relapse by the end of the follow-up. The follow-up was different, but it ranged between 2 years and 28 months. Though I need to mention here that by the end of the follow-up, no biopsy was done. So this is one of the side effects or the points, the negative points of this study. So at the completion of the treatment, 3 months after the treatment, the biopsy was done, but not by the end of the treatment. And they shared a couple of examples of their patients, a nodular lesions on the upper lid. So this is 4 weeks from treatment, and this is 3 months after the treatment with a complete resolution, proven clinically and pathologically. Another lesion here. I apologize for the photos, but it was like this in the original article, black and white. It's not colored, with a complete resolution of all lesions here and there. Again, no biopsy was done by the end of the follow-up. They concluded, and I quote their words, on the basis of our experience, we believe that imiquimod may be a useful first-line treatment, in patients with small nodular basal cell carcinoma who refuse surgery or have other coexisting pathologies that contradict surgery. Another group from Brazil published their data on the ophthalmic plastic reconstructive surgery on 2010. So they recruited 10 lesions from 8 patients. In this study, they recruited only primary basal cell carcinoma, so no recurrences, no failure of treatment, all primary. And they followed the patients for 24 they followed the patients for 12 months. So for the total follow-up was 1 year. They used the treatment 5 times per week for 8 to 12 weeks. At the 12 weeks, they repeated the pathology by 2 millimeter punch biopsy. A positive biopsy was an indication for surgical treatment. So that's it. Failure of medical treatment put the patient for surgery for sure. And they reported a success rate of about 80% clinically and pathologically. The main side effects or the adverse reactions were superficial punctate keratopathy, allergic conjunctivitis, as well as erythema, crusting, and ulceration, and bleeding as expected. This is one of their examples, a big lesion of the lower lid. This is in the middle of the treatment. This is by the end of the treatment, which showed complete resolution. This is a failure patient or a partial resolution. Now, always keep in mind the inner canthus or the medial canthus is an area that is difficult to eradicate and is a high risk of invasion to the orbit because of close proximity. So we won't play with those patients. Now, even the patients with the partial improvement, they showed a significant decrease in the size of the treatment, in the size of the lesion. And I put those in arrows here. Now you can see that the baseline, the tumors were large. After the completion of treatment, although did not resolve, but it shrunk big time, which made the surgery or the further surgical treatment even easier, and the need for complex reconstruction less needed. Now, here I should mention that 6 out of 10, they had lesions, difficult lesions at the inner corner, at the medial canthus. So 6 out of 10 were difficult patients to be treated. And to be honest, I'm not quite sure that this is the best modality to treat such high-risk patients. Anyway, failure of treatment put the patient immediately and directly for surgery. So even when the patient with the lesion did not resolve completely, treatment reduced the size dramatically, which facilitated further surgical intervention as mentioned previously. So the same group from Brazil, this time in 2015, they did a prospective study. So they recruited 24 patients with a prospective follow-up in 5 years duration time. The same regimen was used, but this time they had more experience. So artificial tears were given to the patients. All patients were put on lubricants. They gave the patient a gel to be used before they apply the cream or the medication to decrease the side effects for the patients. And they did, again, 2 millimeter trifine punch biopsy for all patients at the beginning, at 12 weeks, and by the end of the treatment. And the treatment period was around the follow-up treatment was ranged between, reached up to 39 months, so we're talking about over 3 years follow-up. They showed a clinical and histological clearance in 89% of patients at 3 months, which means immediately after the completion of treatment, and 84% at 39 months. So they recruited 24 patients. 3 patients declined the treatment because they developed some serious side effects, or they could not tolerate the medication, so they were excluded. 1 patient passed away, unfortunately, and 1 patient had a massive CVA, cerebrovascular accident, which was not attributed to the medication. So they ended up with 19 patients. From the 19, 17 had a complete resolution, and 2 patients had residual lesion. Of course, the residual lesions or the residual patients had a surgery. And again, if you allow me to mention here, even patients who did not, so zeros means complete resolution. Now, the patients with the partial resolution, if you look here, the largest diameter before the treatment was 12 millimeter. The treatment resulted in 4 millimeter, 4.25 millimeter residual lesion, and this one is a big lesion, 27, was shrunken to 7.6. Now, let's stop for a minute and discuss the surgical management. Now, our golden standard treatment is surgery, and we usually take 2 millimeters for safety margin. So if you 12 millimeter, if you take 2 millimeter from here and 2 millimeter from there, we're talking about almost 16 millimeter lesion or defect that you need to reconstruct. On the other hand, if you add those 4 to this 4, it means 7 to 8 millimeter, which you can close directly with simple canthotomy, cantholysis. This patient, the other one, would have needed a big glabellar flap to reconstruct the defect in the inner canthus. On the other hand, only a simple excision and direct closure was done because the tumor has reduced in size. These are a couple of patients with examples. So lower lid nodular lesion. This is the patient after completion of treatment, and this is a medial canthal lesion, treated successfully, but resulted in some hypopigmentation of that area. This is a patient, so this is the same patient. This is a patient of the recurrences, or the 2 failures, I would say. This patient in the middle of the treatment developed a reaction that was thought or was diagnosed as preseptal cellulitis. So the treatment was stopped, and he was given antibiotic. Then the treatment was restarted again, but that was a failed case. Was the interruption of the treatment a predisposing factor for failure? We don't know, but surprisingly, one of the patients who developed a side effect did not resolve completely. Conjunctivitis is reported as high as 95%. 84% had SPKs and foreign body sensations. Tearing was reported in 58%, and 1 patient had ectropion, but did not need surgery, and 1 patient had the preseptal cellulitis, as I mentioned. It is important to mention that all side effects resolved after completion of treatment with no needed further treatment, or either medical or surgical. This is a table that compared some of the case series. Now, as I mentioned earlier, all case series are small. In the eye, I talk about the periocular region. The present study is 19. This study is from Germany. They reported 100% success rate, and they followed the patient for 7 years without recurrence, but they did not do biopsy by the end of the 7 years, so it was only a clinical decision. This is the group from Spain. They studied the 15 patient and they did the biopsy at 3 months only, not by the end of the 2 years. And all other case series they have small numbers of patients. Now another group from Spain, to make it more attractive, they compared patients with going for radiotherapy or radiation therapy and patients with imiquimod for periocular eyelid basal cell carcinoma. So they recruited 27 patients. It was a randomized cohort. Patients with birth date at an even number were randomized into imiquimod group, and those patients with the odd birth date was put in the radiation therapy. So they recruited 27 patients, and they excluded previous treatments, of course. So all those patients were primary basal cell carcinoma. They excluded patients with genetic disorders or dermatological diseases as well. Of course, biopsy was done by the beginning. Now, by the end of the study, at 2 years, all patients had complete resolution. All patients by 24 months. I'm sorry. The interesting thing here is to mention during the treatment time. This is the imiquimod group was 15 patients, and the radiation therapy was 12. The interesting thing here, during the medication treatment, during the duration of the treatment, those patients had a rough course. They had a bad tolerability of the medications. 7 of them, so half of them, had reported bad tolerability of the disease. But by the end of the treatment or the trial, everything got resolved. On the other hand, patients with radiation therapy reported an excellent and good tolerability of the medication or of that modality of treatment. But by the end of the course or the end of the treatment, 2 patients developed ectropion, 25% developed dry eyes, and all patients, 100% of them, they had madarosis, they lost their lashes. So during the course of the treatment, yes, it's a rough course, but by the end, it's a happy results, I would say. On the other hand, the radiation therapy, during the treatment, tolerability was good, but by the end of the treatment, other side effects developed. These are a couple of examples. This is the imiquimod group, nodular lesion, ulcerative lesion, all treated by the end of, resolved by the end of 1 year. And this is the radiation therapy. As you can see, the patient lost their lashes at the lower lid. 2 of them developed ectropion, which needed surgical correction. Now, to evaluate the cosmetic evaluation, the same ophthalmologist examined all patients, and he reported an excellent outcome for the patients with imiquimod group and good for the patients with the radiation therapy group. Excellent was defined as clinical remission without skin alteration. A good result means clinical remission with hypo or hyperpigmentation of the skin. Now, another group from Greece in 2010, the British Journal of Ophthalmology, reported the use of imiquimod with cryotherapy for advanced periocular basal cell carcinoma. So patients were, 3 patients were recruited. They refused surgery. They had big lesions with advanced periocular basal cell carcinoma. They received the treatment for 8 weeks. 8 weeks. Uninterrupted of imiquimod, and 3 sessions of cryosurgery at 2, 4, and 6 weeks. All of them, they had disease-free at 1 year after follow-up, which I believe is still a short duration for follow-ups for such a disease. Now, they shared this is one of the patients. This is during the cryosurgery. This is 4 weeks after treatment, and this is 12 months with complete resolution. Now, another patient with a difficult large lesion in the medial canthus. Again, this area is difficult to treat. This is 2 weeks post cryosurgery or cryotherapy you can see the intense erythema and ulceration and reaction locally 4 weeks after completion of treatment, and at 6 months the result is pretty acceptable. Now, we need to mention that most of the studies were done for superficial, straightforward, small nodular lesions, not for such advanced cases. Danish Silva, who came here a couple of years back from Australia, they looked into not the effect or the results, they looked into the tolerability of the disease, of the medication in patients receiving imiquimod for either for basal cell or for other indications. So some of those patients received the imiquimod for actinic keratosis, some for molluscum contagiosum, some of them for Bowen's disease, a couple of them for basal cell, yes. So they did not discuss the success rate of the treatment, but they discussed at this paper in the British Journal of Ophthalmology the tolerability and the side effects of the imiquimod group. So over 5 years, they looked into 47 patients. They excluded all patients with ophthalmic conditions or were all patients with current or on ophthalmic medication. So no lubrication was given, no steroid were given, no gel was given, and they followed up the patient accordingly. So they saw the patient every 2 weeks during the treatment, and then 6 weeks by the end of the treatment. And this is the list of their complications. Mild conjunctivitis in 11 patients. 4 out of 47 had a severe conjunctivitis in which 3 of them preferred not to continue with the treatment. They had a severe conjunctivitis, so they stopped it. 1 patient developed a microbial keratitis. It was a Staphylococcus aureus, proven by culture, which responded successfully to chloramphenicol and FML with no residual effect on vision. Another patient had developed a cicatricial ectropion, needed surgical treatment, and 2 patients developed orbital preceptal cellulitis. This is the patient with cicatricial ectropion, as you can see. She developed a cicatricial ectropion. She underwent ectropion surgery and did very well. And 2 patients developed a cellulitis-like picture. Although they were not sure, is this infective? Is this an infection, infective or preceptal cellulitis, or it's chemically related to the medication itself? The medication was stopped. They were given broad-spectrum antibiotic. The cellulitis resolved, and then the medication was resumed again, and they did very well, and they did not have any further complications. So till now, we don't know is that cellulitis related to the medication itself or not. So to conclude my talk, for the 3rd time, I would mention that surgical management is still the gold standard treatment for basal cell carcinoma. Biopsy should be done and performed for all lesions with suspicious basal cell carcinoma. Imiquimod cream 5% might be an attractive alternative to surgical treatment for periocular, superficial, or nodular basal cell, but not the advanced or the morphiform basal cell carcinoma. Imiquimod may be an alternative solution or treatment, especially for old, impaired persons or patients who refuse surgery or have coexisting pathologies that contraindicate surgery, or in cases of very proximity to vital structures like the lacrimal system. Conjunctivitis, erythema, and keratopathy, mild form of keratopathy, are the most frequently reported side effects of imiquimod. Further studies are needed with larger samples and longer follow-ups, and proven with biopsies are needed and expected to provide more accurate information on this modality of treatment. Thank you very much. These are my references.
Thank you, Dr. Hattan. Any questions?
Yeah, my question to you is, this is a lay layman's question. Is there a viral origin at basal cell carcinomas? This seems to be working more on lesions that have maybe a viral origin. So I'm just wondering. And the other thing I noticed that in practically every single case that was mentioned that was shown with pictures, there is a depigmentation. So does this medication work on melanocytes or cells that carry melanin?
Yes. Let me start with the second question because I know the answer during my review. But it was the medication imiquimod was used to treat lentigo maligna or patients with melanoma in situ as well in some small case series. As a matter of fact, the famous Shields and Shields, they reported, I believe, 12 patients of patients with lentigo maligna disease, which were all treated successfully with imiquimod treatment. But I did not mention those studies because I concentrated mainly on the basal cell part. Regarding the viral infection, I'm not quite aware of this, not to my knowledge. Viral infections maybe have been maybe postulated or proposed in lymphoma development of the eyelid, I would believe, but not to my knowledge in the basal cell carcinoma. The most, I would say, and the well-expected risk factor for this is ultraviolet light exposure. Professor Hibani, do you have any comment about the viral?
I'm not aware.
Basal cell carcinoma. That's a huge number.
Yes.
Is that based on a white population or based on, African Americans as well? I mean, how did they make that calculation?
Well, we know that pigmented people or darkly pigmented people, they are safe, I would say. So they are safe, or they're not susceptible or predisposed to get skin cancer in general. So I would assume those are dermatological studies for sure. They're not ophthalmology. I would assume that the fair and light skin is an important risk factor for that. Now, most, if I'm not mistaken, the highest prevalence of basal cell is in Australia, if I'm not mistaken, because they have very strong sun there and they are light colored. But most of the epidemiology studies were not, they did not differentiate. But we know that the darkly pigmented people, they're safe from getting such a disease.
Dr. Saud Al-Khiary.
Thank you, Hattan, for excellent informative lecture. As you know, the xeroderma pigmentosa, they have high tendency to develop basal cell carcinoma and other carcinoma. My question is there any role for the cream for the prophylactic, as through prophylactic? Is there any study or is there any trial?
Yes, absolutely. Absolutely, you're right. There have been some studies about the treatment, the use of imiquimod in xeroderma pigmentosa patient. Again, I reviewed, but I did not include in the spectrum of the lecture.
I think the prophylactic.
Sorry?
Not the treatment. Prophylactic.
No, not to my knowledge.
Is there any trial from your side to try it as a prophylactic?
As a prophylactic, where do you want to apply it? So those patients, they have a defect in DNA repair, and we know that they're more prone to develop a lot of skin cancers. A lot of reports, I would say, they showed a strong evidence of resolution of skin cancers in xeroderma pigmentosa and basal cell nevus syndrome as well. I think this is a very good modality of treatment for such a disease or such entity. I remember during my fellowship with Dr. Hattan Al-Khiary, I operated in 2 years. The fellowship is 2 years. I operated in a Yemeni patient 4 times. That was only during my fellowship. I don't know how many times did Dr. Hussein repeated his surgeries. And imagine reconstruction, getting flaps, doing grafts from diseased skin in such entity or such disease is very difficult, very difficult. So in 2 years he developed 4 cancers which needed surgical treatment. I think this is a very good treatment to or a good modality or alternative to surgery in such disease as well.
Thank you.
Shukran.
We'll have Dr. Zahrani, then Dr. Misfer, then Dr.
Thank you, Hattan, very much. Regarding in your review, did they use these medications in squamous cell carcinomas
Yes.
in the conjunctival and lid?
You mean conjunctiva? I didn't see conjunctiva, to be honest. Now, to be honest, if you read the manufacturer information or the company, they say they mention not to use in the eye or around the eye. So I'm not aware of conjunctival squamous cell, but for skin squamous cell carcinoma, yes, there have been reports with good improvement or good resolution. But to conduct a study, you need numbers, and the numbers of basal cell carcinoma are higher than squamous cell. That's why I believe most studies in the literature, they involved either patients with basal cell carcinoma because they are more, or patients with very bad disease like melanoma or other diseases that we know that are life-threatening.
So this medication comes only in cream forms? Did they have in drops or?
No,
No,
not in the drop form, only in the cream form. Yes.
Dr. Misfer.
Thank you very much, Hattan, for a very excellent presentation. I'd like to have 2 questions. Is this medication available in Saudi Arabia?
Yes,
first?
yes.
Okay.
Yes.
My second question is, there is a trend, especially for those girls who's looking for beauty, to go to a tanning bed. And it's been reported that there is a high risk for basal cell carcinoma after exposure. For this reason, the possibility of viral is not there at all. And I think it's maybe we should give alert to those young girls who is looking for tanning,
Yes.
to be careful when they go to the tanning beds.
Now, regarding the first question, the medication is available in Saudi Arabia. Of course, as ophthalmologists, we don't use it. It's available in dermatological practice. I contacted a couple of my friends from National Guard and Military Hospital, and they said, yes, it's there. It's very effective. They use it mainly for other than cancer patients. They use it for genital warts, for actinic keratosis, and for other modalities or other diseases. But it's there, and it's very effective, and they're happy with it. Regarding the second point, yes, it's some of the studies attributed the increasing numbers of basal cell carcinoma in the community or in the population is to the tanning and the sun baths and these things. So always the dermatological advice is to use a sun protection, a potent sun protection. The regular sun protection that we use, SPF 15 and 10, this is nothing. This is nothing. Dermatologists usually advise or recommend to use the creams or lotions with SPF 40 or 50, especially in a strong in areas with very strong sun, like in Saudi. Alhamdulillah, I don't think we see this a lot because we're fairly dark in color, so and we're not light-colored population. That's why we don't see it in Saudi Arabia a lot.
Dr. Samnan.
Thank you, Dr. Hattan. There are new studies about vismodegib oral treatment, and it was studied for periocular and orbital basal cell, and it showed a very promising result.
Yes.
Can we listen to your comments about it?
I reviewed a couple of them. You're right. It's labeled or categorized under the smoothened inhibitors. Now, they identified a cascade of reactions, I would say, at the level of the cellular level. They called it Sonic the Hedgehog, the Al-Qunfudh, Sonic the Hedgehog cascade, which resulted in those mutations resulted in development of skin cancer. So that modality of treatment, the visodegumab, was successful in interrupting that cascade, this hedgehog cascade, and resulted in a very good treatment of such patients. Again, it's newer than compared to imiquimod. You are right. Studies are few, and numbers are few as well. It's a systemic medication given orally, and it's showing good results, although most of the maybe cases I've seen or I've reviewed are related to the genetic predisposition of such a disease, especially in Gorlin-Gold syndrome or basal cell nevus syndrome. Professor Hibbani, any comment about
Yeah, I agree. Even it's been used for other tumors, not only basal cell. And it's been like more studies are coming, and hopefully in the future will be a good conclusion about it. Still not the gold standard yet. My question to you, Dr. Hattan, this medicine been available for more than 10 years, but
More.
still not the gold standard. Do you think that it's gonna be, and if yes or no, what the reason?
I think it's gonna in the near future is gonna play a good role in treating basal cell carcinoma. Now we as ophthalmologists, because of the proximity of the eye, usually we don't like to give like strong potent medications. You saw some of the pictures are scary. That's why maybe I would assume as ophthalmologists we don't have a lot of studies in the literature studying the periocular lesions. But if you consider the whole body, like a trunk or in the limbs, it is very, very effective. And the complications or the side effects are less because there is no eye, there is no conjunctivitis, there is no SPKs, no lacrimation, no ectropion. So most of the side effects are erythema, hypopigmentation, hyperpigmentation. If now again, at the eye, at the itch zone, again, as I mentioned, we are in a high-risk area or a danger area. If you tell a patient who had like a trunk or a neck maybe lesion that you have a cancer and this treatment will cause you like a hypopigmentation, I think he would buy it, he would go for it. Especially, again, most of those patients are elderly. Most of them, they have comorbidities. Some of them, they're not cleared for surgery. I remember I saw a patient in my fellowship in Canada, an over 100-year Chinese lady with very bad Alzheimer's, with very bad Parkinsonism, was also on his two antiplatelets for a bad CVA, and she developed a lesion over the brow, over her brow. We could not clear her to treat her with a surgery, so we referred her to a dermatologist, and they used 5-fluorouracil. She improved and resolved. So I believe in some circumstances, medical treatment, not surgical, is feasible.
So is it now the gold standard in the trunk and extremity, or still the surgery is the gold standard?
Where exactly?
In the trunk and extremities, is it the gold standard or not yet?
Now, in the body or the trunk, all modalities are very, very, very good and very effective. Cryosurgery, PDT, imiquimod surgery, they're all like in a very good results or effectiveness, I would say. We as ophthalmologists, we still think that the surgery is the gold standard treatment for such disease.
Dr. Saud?
For this nice review about this topic. Regarding the use as first line or second line treatment, just a comment. Most oncologists in general, they don't like incisional biopsy because they think that any incision in the tumor with the blood may increase the risk of spread. That's why if you want to plan to start this treatment, you should do it depending on the clinical diagnosis rather than biopsy. If you want to go to the biopsy, it will be excisional rather than incisional. I am telling this introduction because the answer to Dr. Said Mtawwa, now few people, ocular oncologists, when they see patient with xeroderma pigmentosa and they see any facial changes in the skin, it could be suspicious for early basal cell, they start empirical treatment with Aldara. They will give it like a prophylaxis or empirical treatment for 1 or 2 months without doing incisional or excisional biopsy.
Yeah, but in a suspicion lesion, as you mentioned, in a suspicious lesion, not like as a prophylaxis.
Yeah, not be
in
like
general.
completely,
Yeah.
but without incision.
Yes.
Because if you want to do it as a treatment, you should do only depending on the clinical diagnosis.
Okay.
Because if you do incision, theoretically, this may increase the risk of spreading the tumor to the local area.
Good
And
point.
also the other question of Dr. Yahya, Aldara, I witnessed one case of use of Aldara. He developed bad keratitis and epithelial defect because of ocular contact. He was described for a lead margin, and the patient, by mistake, he was putting in his eye. It was very toxic to the eye.
I didn't go in details on how they treated the patients. Now, they had like a regimen or what to do to install lubricants and then to put a very viscous gel in the eye before they use the treatment, especially for close lesions to the eyelid margin. Now, regarding the biopsy point, very well taken point. Most of those studies, because they're trying to not to do surgery, they're trying to study the medical treatment. So they did the only punch biopsies. The 2 millimeter punch biopsy, it's a trifine that has very thin, very sharp, I would say, instrument. Just a punch biopsy from the lesion just to know. Because you're not quite sure, is this basal cell? Or is it something more aggressive? Now, I need to tell my patient that this is basal cell. It will need years and years to grow. There is less than 1% chance that this get metastasis and these things. So when you're right, when we do like an excisional biopsy, I agree with you. Most of the studies nowadays, if they want to use the imiquimod, they use a punch biopsy, which is, I would assume, is a lower risk for metastasis or for the dissemination of the disease or the cells, malignant cells.
Okay, by this we conclude, and thank you so much for attending this keynote today.
Thank you.
Thank you, Dr. Hattan.